you talk about the anatomy and physiology of the nervous system for neurological disorders, the neurological system or the nervous system is not fully functioning at birth. That continues to mature through the first 12 years of life. There's two separate systems involved, the peripheral nervous system and the central nervous system. You can see that or read what that involves in each one of your notes. When we talk about assessing the child with a neurological disorder, there's lots of things we need to ask about. We want to ask about what kind of signs and symptoms has the family been noticing, or the child if they're old enough, any past medical history, family history, anything that could certainly be a clue as to what is going on and possibly lead us to a diagnosis. Some of the symptoms, or at least generic symptoms that we can easily assess for or see a lot in neurologic disorders are headache, unsteady gait, and lethargy. But those are pretty insidious, so that could be really anything. Again, when you're getting a thorough exam and health history, that's going to lead us to more clues about what's going on. When we talk about their health history, oftentimes their symptoms are the first thing that will reveal a neurologic disorder. Important again to obtain any history about mom's birth history, any neurological problems that could have occurred in utero. When we're at primary care visits and those well child visits, really important to assess the child's developmental milestones and the ability to perform those age-appropriate tasks, because those are key indicators as to if they're on target or not developmentally, and certainly can be clues to their development. Of course, it's important to do a detailed neurological exam. There's 6 areas that we assess. First one is the cerebral function, so that's really getting at their level of consciousness, their orientation, intelligence, performance, mood, general behavior. And then we look at the cranial nerves. Detailed assessment of the cranial nerves, you can see all those on this slide, and of course in your notes as to which cranial nerve goes to what. It's important to assess those as part of that complete neuro exam. I'm not going to make you memorize, what cranial nerve goes to what. So I just want you to be aware that you do have to assess that as part of your detailed neuro exam. As well as we get into assessing, one of the things I want to talk about, which is on the next slide, is strabismus, and I'll continue that there. And just to finish up on part of the detail, the 6 areas that we assess besides the cranial nerves and the cerebral function, we also look at the cerebral function, so looking at their balance and coordination. Motor function, so that's evaluating their muscle size, their strength, their tone. Sensory functions, number 5. They should be able to distinguish, light touch, pain, vibration, hot, cold, and reflex testing, especially deep tendon reflex. Especially newborns, looking at their testing is important because infants can't always perform tasks on command. So we rely on reflex testing to be able to demonstrate that full range of neurological function. When you're doing the detailed neuro exam and you're looking at those cranial nerves, you do want to definitely look for strabismus. And really what I want you to get out of this is, looking for strabismus, you need to ask, is this something that is a new symptom for a child? Asking the parent that, or is this something that was pre-existing before other symptoms came about? Because that certainly can be an indicator of possible neuro problem. Or if it was pre-existing, that could just indicate that we have a weak eye muscle. And strabismus is basically cross-eyed. And a lot of times it can be due to a weak eye muscle, but if it's something that is new, that could certainly tell us there's something neurologically going on. So it's really important to ask, again, was this pre-existing, or is this... We talk about the diagnostic testing that happens with neurological disorders. There's all kinds. You can see the whole list of them in your notes, but some of the big ones that we do, a lumbar puncture and testing cerebral spinal fluid is a big one for certain disorders. We can do ventricular taps, especially off of shunts if they've got a internalized shunt. We can do x-rays or CT or MRIs, giving us some imaging studies. We can do nuclear brain studies. We can do EEGs. So looking at their brain activity. And then this slide and the next one is just examples of what EEG monitoring or testing would look like. When you talk about health promotion and risk management in the kids, this really kind of goes back to our growth and development that we talked about at the beginning of the semester. It's really important to keep those routine health maintenance. It gives us a great time to see their growth and development and to do those developmental milestone checks, looking for certainly early key indicators of if there's anything going on. It's a great time that we can, screen for those kind of problems. Gives us a chance to do immunizations. Think about safety matters, how we can do education with parents and child if they're old enough, about making sure what safety measures we can put in place. Using proper child restraints, seat belts, car seats, where to ride in the automobile. Especially, an infant. Think back to how does an infant need to be facing? They should be rear facing. Wearing that protective gear during playing sports, wearing helmets, especially bike riding, sports injuries, things, or I shouldn't say sports injuries, trying to prevent sports injuries. Wearing all the safety equipment that's needed to prevent any further issues is really what we're getting at with health promotion and talking about neurological. Right, so the first thing we're going to talk about, it's not really a disorder as much as it is more of a symptom or signs and symptoms that we do see with a lot of our neurological disorders, and that's increased intracranial pressure. It is not a single disorder, but like I said, a group of signs and symptoms that do occur with a lot of neurological disorders. So it's really important for you to get a good grasp on what intracranial pressure is, what it looks like, what the signs and symptoms are, how do we diagnose, how do we treat, what's our nursing care. Because if you're able to get a good grasp on what increased intracranial pressure is, then you can take this and apply it to a lot of the different disorders that we're going to talk about. So let's go through increased ICP. And again, important signs and symptoms to look at on your notes on page 4, where you have that little chart and it says signs and symptoms. The first one, looking at increased head circumference. That's important. It's one of those things we do as part of, especially in the infant period, measuring that head circumference, because we're looking for too large of an increase in the head circumference. That could tell us there's something else going on, maybe too much CSF fluid, something's closing, or our cranial sutures, well, hopefully they're not closing too fast. You wouldn't see, if they were closed, you wouldn't see an increased head circumference. But again, head circumference can tell us a lot about something else going on, and it can, if we've got too large of a head size for age or too rapid of an increase, that can tell us we need to do some further investigation. The next one, talking about our fontanelles, which kind of goes right along with our head circumference. We don't want the fontanelles to close too soon, which in an infant, sometimes seeing the open fontanelles, it's important to assess those. We don't want them closing too soon because that can certainly lead to various problems. But again, what we can see when we're assessing those anterior and posterior fontanelles, especially more so the anterior, since that's the one that stays open the longest, is looking for a tense, bulging fontanelle. Because how should it be? It should be fairly flat or just slightly depressed. It should be soft. We don't want it bulging and tense because that tells us, again, increased ICP. Something's changing. Sometimes it's a little harder because in infants, because they can compensate that way because their cranial sutures aren't closed. So they can compensate for a while before you start to see more increased ICP or more signs and symptoms of increased ICP. Vomiting is certainly another indication. Usually we see it on awakenings in the morning or after a nap. Sometimes it can be projectile. Looking at eye changes. Diplopia or double vision is certainly something that we often see. Another one, what we call setting sun eyes, which is, there's an example on the next slide, but that we see in infants oftentimes. That's where the white of the sclera is evident over the pupil, so it limits their visual fields. Vital sign changes. When we have increased ICP, or we have an elevated temperature and blood pressure, but we have decreased pulse and respiration rate. Pain is another one. Headache is often the most common sign and symptom we'll see, especially present on awakening and standing. This is obviously going to be more your older kid who's going to complain about this. An infant can't complain and tell you their head hurts. But we see it also increasing with straining with a stool or holding their breath. And the last one, mentation, talking about their consciousness, their irritability, altered level of consciousness, such as sleepiness. Other signs and symptoms, we'll go through those here in just a little bit, but you can see, especially on the next page of your notes, or even on this slide actually, which is the same picture that's in your notes, some of the different things. But those are the big ones that we can see. When we have increased ICP, what causes the increased ICP? Well, it's because there's something else taking up space. We only have so much room for CSF, for brain matter, for blood, for all the parts that of the brain. If we get a tumor or we get too much CSF fluid, then that's taking, or let's say a head injury that you get a bleed, that's taking up too much space, which then pushes on everything else. So again, we can get increased ICP because of an increase in CSF volume, blood that's entering the CSF fluid, cerebral edema from a head trauma, infection like meningitis or encephalitis, a brain tumor, something that's taking up space in there, and of course development of hydrocephalus, which is too much CSF fluid on the brain as well. Again, infants can compensate a little bit longer because of those open fontanelles, so it allows for things to allows for things to expand and giving them a little more room. Where an older child, or once those cranial sutures are closed, you're going to see signs and symptoms a little bit quicker, because think of it as a closed space. There's nothing to move. So as more things get in there, whether it's a tumor, blood, too much CSF fluid, it's just creating that pressure because it has nowhere else to go. When you talk about the assessment of increased ICP, we can do some very quick procedures: vital signs, pupil response, level of consciousness, motor sensory function. Some of those things we can just simply observe when we go in a room. Others we got to do a little bit, but it doesn't take much to do to assess those things. We can do more elaborate monitoring like EEGs, things like that, or we can certainly put in, we'll get to it a little bit later, we can monitor the pressures in the brain by putting in a bolt and measure those things as well. When we talk about, again, those early signs and symptoms, headache, irritability, restlessness, they're very subtle. But again, as pressure on that brainstem continues to grow, what it does is causes the pulse and respirations to slow. And then compression on those cranial nerves, or the cranial vessels, leads to a compensatory increase in your blood pressure. Pressure on that hypothalamus causes an increase in the body temperature. Again, older children may report the diplopia or the double vision. We can see pupil changes, looking for, when you're doing your pupil assessment, looking for those changes, looking for strabismus, nystagmus, those sunset eyes, inability to follow light or follow those commands. They're all important assessment pieces. And we'll continue talking about assessment here in a couple. This is just an example of showing the sunset eyes, and you can see in this picture where the lower lid, it's a little bit harder to tell on this one, lower lid is coming up over, usually covering over about half of the pupil, and you see more of the top of the white sclera part of the eye. And that's what sunset eye. As part of our assessment with increased ICP, one of the tools we use is the Glasgow Coma scale. And it's a 3-part assessment. We look at the eye-opening response, the verbal response, and the motor response. The higher the number, the better off they are. We want a high number in this scale. The low number, or a lower number, certainly tells us there's more going on, or we have more problems, and not as good. Usually we see more severe trauma the lower the score. Some of the other things we want to look at, I'll continue in the next couple of slides. Oftentimes with increased ICP, sometimes we will see posturing. So we can see the flexion or the extension. Flexion would be the decorticate, which indicates there's a cerebral loss. That's when the child's arms are adducted and flexed on the chest with the wrist flex. and hands fisted. And you'll often see plantar flexed feet as well. Legs will extend and be internally rotated. And oftentimes you may see some fine tremors or intense stiffness. An extension is the decerebrate, which often tells us there's a midbrain malfunction or it's not functioning properly. And you'll see that rigid extension with the abduction of the arms and pronation of the wrist with the fingers flexed. And the legs are extended with feet plantar flexion. This is just a nice pictorial if you're a visual learner that kind of puts everything together with increased ICP, or what our etiology kind of patho is, signs and symptoms to look for, to how do we diagnose, how do we treat, what are our nursing interventions. Same thing that you have in your note. I'm not going to go through that anymore. You can read through that if that is something that is helpful for you to look at. I had mentioned earlier that sometimes we can do more invasive monitoring. One of the ways we can do that in monitoring our intracranial pressures is by doing different types of ICP monitors. There's an intraventricular catheter, a subdural screw or bolt, and even a fiber optic sensor that can be implanted. And that way we can monitor more closely what those pressures are in the brain. You don't have to memorize the different types of pressure monitors. Just know that that's certainly something that we can use to monitor for increased ICP. Again, this picture is just an actual example of an ICP monitor, but as well I'll go ahead and talk about what the therapeutic management typically looks like for a patient, or what we do for a patient with increased ICP. Of course, we need to identify what is the cause of the ICP so that we can quickly remedy it and prevent any brain injury or compression to the brainstem, because certainly both compression to the brainstem or injury to it can lead to a cardiac and respiratory failure if we don't do anything. It's important to assess those actions like coughing, vomiting, sneezing, rapid administration of IV fluids, because that can increase our ICP as well. Measures that we want to take to reduce ICP: place the child in a semi-Fowler's position. We want to administer, yes, we would follow the orders, but they'll administer a corticosteroid like dexamethasone or Decadron, because that's going to reduce the cerebral edema and accompanying the pressure, the pressure that's accompanying it. Give them an osmotic diuretic like mannitol. That's going to help shift that fluid from the extravascular compartments into the vascular stream, thereby reducing their pressure. We can do lots of different things, but those are the big ones. We'll talk more about nursing care that will help help decrease that increased ICP. Okay, let's talk about some of the nursing care measurements that we can do to help a child who has increased ICP. And to help reduce some of that. What we can do is certainly avoid those activities that increase any ICP, and eliminate or minimize environmental noises, because that just makes them more agitated. We want to elevate the head of the bed 30 degrees, and of course position the child's head midline, because that's going to help facilitate that venous drainage, avoid any jugular compression. Nutrition and hydration is really important. We want to do intravenous administration of fluids and parental nutrition. Depends on how severe the ICP is. Obviously, if they're sedated, then that's how we're going to give fluids and nutrition. But we do have to be careful with overhydration, because overhydration can certainly lead cerebral edema, which can lead to increased ICP. We want to avoid the overeating and feeding, because we don't want them to vomit. That vomiting will increase their ICP. We have to watch and be alert for altered pituitary secretion, especially looking at the syndrome of inappropriate antidiuretic hormone or diabetes insipidus. These often can accompany the central nervous system diseases, and that's usually a result of the hypothalamic dysfunction. Medications as indicated or as ordered. Again, what we talked about earlier, the osmotic diuretic like mannitol, because that's going to help with cerebral edema. Sedatives and antiepileptics for seizure activity. They often do this as a precautionary, even if they've not had any seizures, because they want to prevent that from happening. And when you have increased ICP, they're certainly at greater risk for having seizures. Sedation is also important in paralytic agents, especially when doing diagnostic tests, trying to reduce those secondary complications. Antipyretics to reduce the fever, because again, increased fever increases, that increased body temperature increases ICP. Thermoregulation, I already kind of hit on that with the antipyretics, but thermoregulation, we want to use antipyretics, cooling blankets, because hyperthermia often does accompany cerebral dysfunctions. Elimination, if they're sedated, well, we can't expect them to get up and go to the bathroom, so oftentimes they're going to need a Foley in that acute phase, and then, eventually progress to diapers or back to bathroom privileges as they're used to. Stool softeners, enemas, suppositories on occasion, because again, we don't want them straining. We don't want them straining while trying to have a bowel movement, because that increases their ICP. Hygienic care, really important, having good skin integrity, assessing skin, looking for pressure ulcers, mouth care, eye irritation, especially in the phase if they are needing to be sedated, if they're in the ICU setting. These things are always important, but especially in that sedated child who cannot move. Positioning and exercise, again, range of motion exercises, stabilizing that head midline, having their head of bed elevated, and any pillows to support other extremities as well are all important considerations to take into effect. And a lot of these are more geared at more severe, the sedated child, because not all children who have increased ICP or are having symptoms of ICP are in the ICU. I've seen plenty of kids out on a regular med-surg floor, but we can still put some of these things into place in our care to reduce the ICP. All right, now we're moving into cerebral palsy. And cerebral palsy, or also known as CP, is a non-progressive impairment of that motor function control, and especially muscle control and their coordination. So again, it's characterized by abnormal muscle tone and coordination. It is the most common permanent physical disability that we see in childhood. Oftentimes, kids with CP also have speech and ocular difficulties. They can have seizures, cognitive delays, hyperactivity, muscle spasticity, gait difficulties. They sometimes, will have multiple problems. The etiology, the exact cause of it is unknown. They think it's they think there's some association with certainly low birth weight, premature birth injuries, brain anoxia injuries, head injuries, infections can certainly lead to cerebral palsy as well. There's two main categories that we to classify CP, and the first one is the pyramidal or the spastic, it's easier to say spastic, or the extra pyramidal or dyskinetic. For study purposes and for testing purposes, I want you to focus on spastic because that is the most common type that we see. But in your notes, I do talk a little bit about dyskinetic, but we're mostly going to focus on, we are going to focus on the spastic type. So with spastic CP, they have an excessive tone in the voluntary muscles that result in upper motor neurons. So some of those manifestations that we're going to see is hypertonicity, an abnormal clonus, exaggeration of their deep tendon reflexes, and they have abnormal reflexes well past the age at which those disappear. So they'll have a lingering positive Babinski reflex. They'll have the continuation of the neonatal reflexes like the tonic neck reflex. If you hold an infant up in the ventral suspension position, they'll often arch their back and extend their arms and legs abnormally. The infant will fail to demonstrate parachute reflex. So that's where if you're holding an infant and you don't really drop them, but you drop down while holding them really fast, what they should do is they should flail out arms and legs. They don't have that when they have CP, so they fail to demonstrate that parachute reflex. They often have, when they start to walk, they'll have, the child with CP will often have the crouched gait and in toe and scissoring, so meaning just if you think about how a pair of scissors work, that's how they walk with their legs. That can certainly lead to tight adductor thigh muscles, hip abductor contracture of the heel cord because they're walking up on their toes. And the spastic involvement, it can affect both extremities on one side, or it can affect all four. Not worried about you, knowing the hemiplegia, the quadriplegia, the diplegia, or paraplegia. Just know that it can affect, same side. It can affect all four. It can affect more just upper or lower. When we talk about how we assess and diagnose and clinical manifestations of cerebral palsy, let's talk about diagnosis first. They diagnose them based on a lot of their history and physical assessment. So certainly any episodes of any possible anoxic injuries during prenatal life or during the birth should be well documented. The extent of the disorder sometimes isn't recognized until the child is starting to complete more complex motor skills such as walking, coloring, because that leads to more muscle coordination, and sometimes you don't see it right away. We can do skull x-rays or an ultrasound, and that can certainly show us changes or asymmetry in the cerebral area. They can do EEGs, but those can be very highly variable. Some of the possible early warning signs that we look for when we talk about the motor function. Some of the motor signs of CP that we will see. They will have poor head control after the age of 3 months. They often have stiff, rigid limbs, arching of the back or pushing away. They'll kind of have a floppy tone or limp body if you go to pick them up, because again, the muscle tone isn't there. They're unable to sit without support at the age of 8 months, because by that time they should be able to sit up on their own. So that's a red flag. Clench fist after the age of 3 months. That goes back to those neonatal kind of reflexes. They're persisting longer than usual. Some of the behavioral signs of CP that we will often see is excessive irritability. No smiling by age 3 months. Use of just one side of their body to play or move around. And they often have feeding difficulties. That persistent tongue thrusting lasts. It doesn't disappear like typical. Frequent gagging or choking when you're trying to feed them is often things that we can see. We get into the clinical manifestations. I'm going to hit the big highlights. You can kind of read through the smaller bullet points, but we'll see, again, delayed gross motor development, abnormal motor performance, alterations in their muscle tone, abnormal postures, those reflex abnormalities that I already kind of hit on. Those are all important pieces to assess for and look for those clinical manifestations. We talk about what our whole goals to therapy of CP. We can't cure CP, but we have lots of different goals that we want for a child with CP. And CP can be, there's quite a variation as to how severe it is. There are some kids who are able walk, talk, and function pretty well on their own. To the other end of the extreme is there's ones who need total care, primarily in a bed or a wheelchair all the time. They just don't have the muscle tone. So you do see a wide variety within CP as to what their abilities are. But our whole goal is we want to make sure we can establish locomotion, communication, self-help skills. We want them to be as independent as possible. Optimal appearance and integration of those motor functions. Correct any deficits that are associated or that certainly affect them. Educational opportunities, that is up to the child's capabilities. So a lot of inclusion in school. There's no reason these kids can't go to school. We want to provide those. Of course, providing socialization as well. Activities, not just school, but getting them involved in other things with kids their age. That's all important. That goes back to that growth and development we've talked about. When we look at therapeutic management, it's all about early intervention and recognition of CP, getting those early interventions in place, and educating parents about what interventions we can do, because we, again, want to maximize their abilities to the best that we can. A lot of them need ankle foot braces or AFOs just to help kind of stabilize, give them some strength. If they are able to walk, it just gives them more stability when they're walking. Oftentimes they'll need orthopedic surgeries to correct contractures. They'll need tendon releases, things like that, because of what that's caused from the spastic deformities. They need oftentimes a lot of different pharmacologic agents used either to treat pain and relieve spasms or for seizures as well. The dantrolene and the baclofen, that decreases your overall spasticity. Dilantin is for seizures, as well as the carbazepine and the valproic acid. Those are for seizures as well. Botox or the botulism A injections, that can certainly help reduce spasticity. Typically they do it upper or lower extremities, and they usually do it in the large muscles is where they'll do those. Dental hygiene is really important for these kids. Again, they don't have the muscle control and coordination, so oftentimes they need help with brushing teeth and things like that. Getting them involved or getting physical occupational speech therapy is really important. Again, it's all about trying to improve their coordination, their self-help, their communication, making them as functional as possible, for lack of a better word. Nutrition is important. If they have problems with feeding, we need sometimes to do some special feeding techniques for that oral motor skill. Sometimes in severe cases they just need enteral feedings in order to have enough nutrition for growth and development. Other things that they can do, it is done on occasion. They don't jump right to it. They can do what's called an implanted baclofen pump. And what this will help do is decrease basically their spasticity. It is something that they're going to try oral stuff first, because this is, again, it's intrathecal, so it goes right into the spinal cord to help reduce that spasticity. Your nursing care related to a child with CP, I've kind of hit on a lot of this, but just to recap, you want to promote self-help as best as you can. Teach about how to give medications, what the medications are for, how to give them, how often, to control the different effects that we see with CP. So anti-anxiety meds, meds to control ADD or ADHD, anticonvulsants, muscle relaxers, all of those things. Safety precautions, and especially seizure precautions, because they often, again, safety precautions because of that lack of the muscle tone and coordination, and they often have, a lot of them do have seizure disorders as well with this, so certainly taking in and placing seizure precautions and teaching the family about those. Provide those recreational activities, again, for socialization. It helps keep them a little more limber, so we're not getting those contractures and that stiffness. We want to teach, maybe some range of motion. Assist the family in devising and modifying equipment and activities that work for their child. There's not a one plan works for everybody. So sometimes we have to modify depending on the child. And of course, it's really important to support the family. Give them a chance to listen to their concerns. Sometimes they got to go through a little bit of a grieving process, because nobody thinks they're going to have a child who has special needs, and that is certainly more work, more care. Doesn't mean they don't love their child. They just need sometimes somebody just to listen to them and to invalidate how they're feeling. But it's important as well, as part of teaching or education with family. Again, I already talked about medication administration, physical therapy, what they may need for that. We're doing range of motion exercises to keep them preventing those contractures, the different mobilization techniques, wearing those AFOs, whether we need a wheelchair, we need a walker, cane, crutches, whatever the case may be, to help them mobilize them as much as possible. Again, those feeding techniques or whatever nutrition that they are going to need if it's enteral feeds, teaching them about those, and of course injury prevention that I already hit on. You already heard the presentation on bacterial versus viral meningitis. I'm not going to go through and lecture on this. You can see it in the notes, and I will also post the student presentation as well if you want to review that. All right, moving on to your paroxysmal disorders on page 21, talking about seizures. We can have seizures, we can have febrile seizures, and we can even get into status epilepticus. So I will go through all of those here and over quite a few of these recordings to break it up a little bit. But seizures, it's a malfunction of the brain's electrical system. So they have the involuntary contraction of muscles. We have different types and causes. I'm not as worried about you knowing the different types, but there's, other than knowing like febrile or getting into status epilepticus. It is important that seizures be differentiated because of their degree of severity and their type. So parents know any kind of special precautions that need to be taken and appropriately managed, and drug therapy as well. The etiology, they can be idiopathic causes. There could certainly be organic causes, as you can see listed there. But typically, when we look at signs and symptoms, sometimes older kids can tell you that they have this aura or a sensation right before a seizure occurs. Those are important clues as to where the seizure is coming from. If there is a sudden change in their posture, like their arm dropping suddenly to their side, I've seen plenty of kids who just drop to the floor. We can see behavioral signs like lip smacking, fumbling hand movements, screaming involuntarily. They may slump to the ground or go unconscious with seizures. You may see circumaural pallor because of a halt in their respirations. So when we do an assessment with somebody who's got new signs and symptoms or varying signs, or I should say different signs than what they're used to seeing, we always want to take a thorough history, especially even thorough pregnancy history, to look for causes as to why a child has seizures. What were the events that led up to the seizure? What happened immediately before? We want an accurate description of the seizure. So whoever was around, what did it look like? What did they see? How long did it last? What did the child do? Investigate what the child's overall behavior has been in the last few weeks. So look for bedwetting, especially in a child who's been potty trained, that has new bedwetting. All of a sudden we see changes in school performance. These can be signs of an absence or nocturnal seizures, and they can often kind of go unnoticed for a while. We talk about diagnosis of seizures. Again, doing a complete physical neurological exam. What are their clinical manifestations that they're having? We can do blood studies to make sure it's not something metabolic or infectious going on. We can do lumbar punctures to make sure, or I shouldn't say punctures, hopefully it's only one, a lumbar puncture to rule out, meningitis, or if there's bleeding in the CSF fluid that would be causing the seizures. So basically trying to rule out any other causes. We can do EEGs, just going to look at our brain activity, CT scans, MRIs, skull, x-rays, because basically we're looking for another cause. So whether it be a brain tumor, we've got increased ICP, something that would be causing the seizures. If all of those things come back, then they probably have a seizure disorder. Our management, it's always about safety first. There's lots of different things that we need to make sure we teach parents how to keep their child safe, and some of the things that we need to do in the hospital. So things, in the hospital, patting the bed rails, don't hold them down, don't ever stick anything in their mouth. These aren't new things to you, just those are some, things to think about. We obviously want to control the seizures and decrease their frequency. We'd love to completely get rid of them. However, that's not always possible, but if we can at least decrease them and get a better control of them, that's better than nothing. Certainly if there is an underlying cause, we want to find what that underlying cause is and treat that underlying cause, if that's certainly an issue. Mostly we do medication therapy. That is the mainstay of treatment. We do all kinds of anticonvulsants. So just to name a couple, there's carbazepine, Tegretol, valproate, or Depakote, there's valproic acid, phenytoin. There's all kinds. Those are just a couple of them. That's usually our first line of therapy, is doing different anticonvulsants. Sometimes they need several. Sometimes they have to change things, as kids grow or as new symptoms appear. If they have a lot of seizures, or if there's something that's causing the seizures, like a tumor, we've got a hematoma of some kind, we can certainly go in and do surgical therapy. So again, if the seizure is caused by hematoma, a tumor, or some other kind of cerebral lesion, we'll surgically go in and remove that, and hopefully that takes care of it. In the kids who have intractable seizures, which is they're having more than 100 seizures per day, they can go in and surgically try and put a stop to how many seizures they're having. Something else that they can do, that if they're having a lot of seizures on a daily basis, they can do what's called a vagal nerve stimulator. And that's an implanted device that helps reduce seizures that have been poorly controlled with drug therapy, and is an adjunct therapy. That doesn't mean you can get rid of the anticonvulsant drugs. It's just an adjunct to the drug therapy. Basically, they tunnel electrodes under the skin to the left vagus nerve, or cranial nerve 10. And what happens if the patient's able to, or if they're not, then the caregiver can activate the device at the onset of a seizure. And they wear a bracelet that has a magnet on it. They wave it over the implanted device, and it will give them that electrical pulse to the left vagal nerve, and hopefully stop the seizure. Anticipatory guidance to think about with parents. Anticipate those, try and get them to anticipate any hazardous situations. We can see plenty of kids with seizures who are able to function on a daily basis pretty independently as they get older. But think about crossing the street, riding a bike. With adolescents, when they want to, or they're old enough to start to drive, they cannot drive until they've been cleared by a primary care provider. And they have to be free of seizures for a year before a physician will clear them. Febrile seizures, often associated with a high fever. It's more common in the preschool age child, but it can occur up to as late as age 7. More serious in the child who's under 6 months, and it oftentimes can occur after an immunization or a live vaccine, because those do most commonly produce fevers. And what happens is we have a sudden spike in the temperature, not a gradual incline. So this sudden spike in temperature is what causes the febrile seizure. The exact cause has to be investigated. We look clinical manifestations, tonic-clonic, generalized. Usually there's possible series of sudden brief symmetric muscular contractions. The eyes roll upward or inward. They have a loss of consciousness, become flushed or pale, or have some cyanosis. And they only typically last for 15 to 20 seconds, but no more than 1 to 2 minutes. And most times what will happen is, parent notices this happens and they call 911, but by the time 911 gets there, it's over with. But oftentimes they're still taken to the ED to be evaluated. So our prevention, what we can do is give ibuprofen and acetaminophen before fever develops. When we have a child who's been diagnosed with febrile seizures, give them, if they've had an immunization, give them ibuprofen or acetaminophen, or if they're sick, trying to curtail that high spike in fever that we typically see. making sure that we teach them that their child still needs to be seen by a healthcare provider to rule out that it's not meningitis. That they'll do a pretty thorough neurological workup to rule that out. That's usually just if it's just the first episode. They'll only truly diagnose them with febrile seizures after they've had a second one. I shouldn't say after the second one, but they'll diagnose them when they've done that neurological workup and they have 2 or more events of a febrile seizure. Again, they'll do that lumbar puncture that I talked about as part of the workup and trying to rule out meningitis. They'll give them medications like phenobarbital, Valium, or Ativan if the seizures continue, just to control that seizure activity. Again, part of our treatment, controlling the fever by giving Tylenol or ibuprofen. Antibiotics only if there's an actual infection present would we give the antibiotics. A lot of it is centered around parental education and support. We want to reassure parents that it's pretty benign nature. After any kind of febrile seizure subsides, we want to encourage parents to sponge the child off with tepid water to reduce the fever quickly. We don't want them putting the child in a bathtub of water because it'd be much easier for a child to accidentally slip out of their hands and go underwater if they would have a second seizure. So again, sponging them off is a safer way. If the attempts to reduce the temperature by sponging off aren't successful, have the parents put cool washcloths on their forehead, the axillary groin area, and take the child to the ER for immediate evaluation. When we do Tylenol to lower the temperature, we don't want a parent to give Tylenol after a seizure has occurred. We really want to do it ahead of time to try and prevent the seizure from occurring. Afterwards, the child is still in a postictal state and we worry about aspiration. So we don't want them doing it after the fact. Suppositories would be a better way of giving it versus oral. And the big one is if a febrile seizure is lasting longer than 5 minutes, they need to seek medical attention right away. So calling 911 versus putting the child in the car and rushing to the ER because we don't want them to get into an accident as well. All right, status epilepticus. That is considered a medical emergency, and that's when you have a continuous seizure that lasts for more than 30 minutes or a series of seizures when the child does not return to their previous level of consciousness. Our management for a child who is in status epilepticus, we'd give them IV benzodiazepine to try and stop that seizure activity. We can give them like Valium, diazepam, but we do have to administer it with caution. We can teach parents to do administration of rectal diazepam at home in case the child would ever get into the status epilepticus. We can give Ativan or lorazepam in children greater than 2 years old because it has a longer duration of action and there's less respiratory depression. They may need O2 if they're becoming cyanotic at all, and may need to monitor blood glucose for hypoglycemia. We talk about the nursing considerations for a child with seizures. This is kind of in general. I hit on some of this a little bit earlier when we talk about the safety of the child. It's about protecting the child from injury. Things you want to observe and need to document on, monitor the time that it starts and finishes. So how long does that seizure last? What behavior changes were noticed? Note any areas of movement, like movement of the body, face, eyes. What's their respiratory effort like? Did they have a loss of bowel or bladder function? We don't ever want to leave the child alone. We want to stay with them, place them in the recovery position because we certainly want to make sure that they don't aspirate on any kind of oral secretions that they may have or if they would vomit. And of course, you need to observe them post-ictally as well. Again, don't ever try and restrain them or put anything in their mouth or between their teeth. We don't do that anymore because we worry about causing more problems. Your general guidelines for safe administration of an anti-seizure medications, you can read through those. I think a lot of it we've kind of either hit on or it's previous knowledge you should. And let's talk about head traumas. Head traumas can be a multitude of different things. We're going to go through a little more, but talking about like skull fractures, subdural hematomas, epidural hematomas, concussions. Those all fall under the big umbrella of head trauma. But head trauma can be caused from automobile accidents, falling from a swing, bunk beds, couch. Other ways we can get head injuries, being struck in the head by something, baseballs. I've seen kids who have been hit by a golf club, a rock, falling off a bicycle, not wearing protective helmet. I've even seen, unfortunately, a child who was wearing a protective helmet, riding an ATV and crashed, and he was thrown from the ATV. And when he was thrown from the ATV, it also knocked off his helmet, and he had a pretty significant head injury. So it is important, again, going back, talking about safety measures to be taken, but just because you always take the safety measures doesn't mean that you can't still get a head injury. Things that children may experience with head injury: minor personality changes, memory deficits, headache, irritability, the postural vertigo. Sometimes we'll see behavior changes where they're more aggressive or having poor school performance. In our immediate assessment in a child who has a head injury, regardless what the injury is caused from, we need to stabilize their neck. So have their neck stabilized with a brace until we can rule out a cervical trauma. Of course, important to do a neurological assessment in somebody who has a head trauma as soon as possible and at frequent intervals, because we want to detect early signs and symptoms of increased ICP. We've already talked about those, so I'm not going to go into any more in depth on that, but we're looking for those increased, or the early signs and symptoms of increased ICP. Other important assessments as well: vital signs, observation of the pupils, their level of consciousness, motor function. And again, this slide, or this picture, which is the same as in your notes, gives you a nice pictorial of some things to look for. Immediate management, we want to do, in general, ICP monitoring, whether that's just looking for signs and symptoms or if we need to do more invasive monitoring. We can do CTs and MRIs because we're looking for any edema or bleeding. We need IV access in case we would need to give fluids or medications, possibly administration of mannitol or administration of dexamethasone. Elevate that head of the bed. So again, it goes right back to your management of increased ICP. This slide is just an example of the echomosis that you could see around the eyes, and the next slide is the example of the echomosis you could see behind the ear when you have a skull. This slide is just showing the example about doing testing for glucose if you have the rhinorrhea or the aturia, how the test strip will test positive for blood if you have, and CSF fluid if that is something that your signs and symptoms. All right, continuing on with your head traumas, subdural hematomas. That is, with a subdural hematoma, that's venous bleeding into space between the dura and the arachnoid membrane. Usually it's bilaterally, and it occurs with a head trauma, and it lacerates those little minute veins in the area. You tend to see this more in infants. Symptoms can occur anywhere from 3 to 20 days after a trauma. You're going to see symptoms of increased ICP that we've already talked about. If there's substantial blood loss, you may have some anemia as well. We can certainly do angiography, MRI, and ultrasound because that's going to tell us to the extent of the hematoma. As the blood accumulates, oftentimes they can remove it by doing a subdural puncture, especially if it's an infant, through the anterior fontanelle. But if that bleeding is still present after 2 weeks, they may need to actually go in and do surgery to reduce that space and stop the bleeding. In older children's, surgery is definitely necessary because that anterior fontanelle is already closed and there's no space to actually go through and tap to drain that blood off. So you can see in this picture, the bottom picture is an example of the subdural hematoma. In an epidural hematoma, we have bleeding into the space between the dura and the skull. And again, usually happens from a severe head trauma. What's happening is there's a rupture in the middle meningeal artery, which thus leads to the arterial bleeding. So this is usually pretty intense and can cause rapid brain compression. At the time of the injury, the child may be able to, or may be become unconscious momentarily, but they'll regain consciousness. They could appear fine for several minutes or several hours. But then they're going to start to develop the signs of cortical compression. So they'll start having vomiting, the loss of consciousness, headache, seizures, hemiparesis. When we do a physical exam on them, they often have unequal dilation or constriction of pupils. They'll have decorticate posturing. And if the pressure continues to go unchecked, meaning increased ICP pressures continue to go unchecked, that puts greater pressure on the brainstem, which can certainly have an effect respiratory and cardiovascular and function and can cause impairment. Treatment, they need surgical removal of the accumulated blood and cauterization of that torn artery. And the epidural hematoma, that picture is shown on the top of this. I'm also going to talk about skull fractures before we move on to the next part. But with skull fractures, basically with skull fracture, there's a crack in the bone in the skull. Obviously, depending on where that fracture is and how severe the fracture is, can certainly change, how severe our ICP is or what our treatment would be like. But we can confirm the skull X-ray, or I should say, we can confirm the skull fracture with a skull X-ray. Of course, we want to get a good history of what the injury was, what caused the blow to the head. Depending on the age of your child, you may be trying to rule out any abuse situations. If they have a skull fracture at the base of their skull, the child's going to usually exhibit echomosis, which I have an example of in the next couple of slides as well. There's some pictures. What you'll see is echomosis around the eyes or behind the ear, as well as you need to look for rhinorrhea or otorrhea, so CSF draining from the nose or the ear. That may be noticeable. That could be certainly, it is a serious finding, because that tells us we have a direct path to our CNS system, which we worry about infection. What we can do if we notice this is we can test the fluid with a glucose reagent strip, and the test will be positive for glucose. If we do have a fracture that is linear, but there's no underlying pathology, there's no real treatment except to just observe them. May need to do a repeat X-ray in 3 weeks just to make sure that healing is taking place. If we have a fracture that is depressed, or a compound fracture, where you've got bone actually pressing into the brain matter, then we would need to do surgery to remove or repair that broken fracture, because we're worried about any bleeding, and of course that puts them at higher risk for infection, higher risk for increased ICP as well. All right, the last head trauma disorder we're going to talk about is concussions, and that is a temporary and immediate impairment of the neurological function, which is caused by a hard, jarring shock to the skull. What usually happens, or what we also call, or is referred to as a coupe, contra coupe injury. So basically, when the head strikes a hard surface, whether it's in a motor vehicle accident or if it's from abuse, the head strikes, and what happens is then the brain will hit wherever that force was on the head inside the skull, and then it shifts back, which causes that contra coupe part of the injury. So basically your brain is shifting inside your skull. Symptoms that we can see, children can certainly have a transient loss of consciousness at the actual time of the injury, so you want to assess that level of consciousness. They may vomit, they may show some irritability, especially after regaining consciousness. They typically have no memory of the event, so they have some amnesia about the event. Oftentimes one of the things you'll see is the kid keeps asking a parent or whoever's around what happened. Even though you tell them, they forget, whether it be several minutes go by or whatever the case may be. They have an actual amnesia of the event. We can do skull x-ray and MRI because we want to make sure there's not a skull fracture. What we're going to do is observe them for 24 hours to rule out any severe brain trauma, edema, laceration, looking for bleed, looking for increased ICP. Oftentimes they can be observed at home by parents. It's important to teach parents to assess the child's level of consciousness every 1 to 2 hours while the child is awake. We don't really wake them up during the night or tell parents don't wake them up during the night because those multiple awakenings every hour to 2 hours can be very disorienting, and then it's hard to tell, is it just because they're confused or is it because of the concussion? So we just tell the parents, wake them once during the night just to be certain that they're conscious, that they can easily be aroused, but not waking them up every 1 to 2 hours. But while they are awake, assessing them more frequently at the 1 to 2 hour intervals for their level of consciousness. If parents have any questions, concern, make sure they know the number that they can call to ask those questions and voice any concerns that they have. And certainly make sure that they know when it's appropriate to call if they are seeing changes in the child's level of consciousness, their behavior, things. All right, moving into some physical and developmental disorders of the nervous system. The first one we're going to talk about is hydrocephalus. So hydrocephalus is we have a imbalance in the production and absorption of cerebrospinal fluid. Typically occurs before the closure of the sutures, which can lead to the enlargement of the skull. So a lot of times we'll see in 90% of infants who have myelomeningocele, which is the other disorder we're going to talk about, they also have hydrocephalus. So hydrocephalus is considered to be a developmental defect, and it's a major problem that can result in what's called an Arnold-Chiari malformation, which is a malformation due to the increasing pressure. In older children, we typically see hydrocephalus because it's associated with a trauma or some sort of space-occupying lesion like a brain tumor. So they're classified as congenital, which occurs at birth, or acquired, which is an incident that later happens in life. Your etiology and patho of hydrocephalus, again, I already said it's an imbalance of the production of the cerebrospinal fluid caused by either there's an overproduction of fluid, an obstruction of the CSF fluid, or an interference with the absorption of the CSF fluid. When you do your assessment, you want to look for any kind of obstruction that's present, excessive fluid accumulation, and dilates the system forward from the point of the obstruction. So symptoms can develop very rapidly, or they can develop more gradually, depending on the extent. And again, remember I talked about infants are really able to compensate because those cranial sutures aren't closed. They still have the open fontanelles. This can even be present sometimes prenatally, and it can be detected sometimes on that prenatal ultrasound, and then it can even be shunted in utero. This is just showing the 4 ventricles that we have, just a graphic for you of the 4 ventricles, and the next picture will show you when we do imaging studies that you can see the changes in the ventricle. So this is just another example of how you can see some of those changes of hydrocephalus. Your clinical manifestations, what you're going to see in an infant, pretty similar to some of the things that we've talked about before, especially with increased ICP. Fontanelles that are wide and appear tense, so those bulging, tense fontanelles. They'll have separated sutures, so their cranial sutures are farther apart than they should be. Their head diameter enlarges. So that's why head circumference is so important. Their scalp often looks shiny, so if they don't have a whole lot of hair, you can see, because as things stretch, it gets that shiny appearance. They'll have dilated scalp veins, frontal bossing, so like think of their forehead, it's usually kind of protruding. Setting sun eyes, that's where the sclera is visible above the iris, so you see more of the top part of the whites of the eyes. They'll show signs of increased ICP, like we've already talked about and that are listed on your notes. I'm not going to go through those again. Irritability, lethargy. Infants have a shrill, high-pitched cry, and it's pretty obvious. Oftentimes you'll hear people refer to it as they have a neuro cry. It is a very distinct cry because of how shrill and high-pitched it is. And they can also have what's called the McEwen sign, or the crackpot sound on percussion. It's a very distinct sound. Nursing doesn't typically do that, but a physician would. But it is just another sign that you can see in an infant. In a child, they'll often complain again about a headache on awakening, or sometimes with improvement after they vomit. And oftentimes they'll vomit when they get up or after meals. The papilledema, strabismus, remember how I talked about it's important to assess if that's something new. Ataxia, irritability, lethargy, confusion, or they're incoherent. We'll see sometimes some behavioral changes. Sometimes parents or teacher will say they've noticed a difference in their school performance if it's more gradual. We talk about detection of detection of hydrocephalus. I'll actually talk about that on the next. Alright, so detection of hydrocephalus. It's treated, obviously, much more effectively the earlier we can recognize it and diagnose it. One of the big ones, especially in infants, measuring that head circumference in newborns within an hour after birth and again before discharge, just so you can get a baseline. And again, then measuring that OFC, or their head circumference, for all children under 2 years of age, because we're looking for a large increase in head size, which could certainly be indicative of hydrocephalus. That's why it's so important to plot those on growth charts and during those well-child visits. The head circumference for all infants should be important, especially following a head trauma, and documenting that in the medical facility. You want to note any asymmetry that is occurring, because that could certainly tell you where the point of obstruction may be. Looking for those clinical manifestations, whether it's of the infant or of the child. So I really suggest you know the clinical manifestations between the infant and the child for hydrocephalus. We can certainly do imaging studies like ultrasound, CT, MRI, X-ray, because that can show us some changes. When we talk about the therapeutic management for hydrocephalus, it really depends on what the cause and the extent is. We're going to use drugs to control the effects of hydrocephalus, so the osmotic diuretics like mannitol, antibiotics usually as a preventative measure, the Diamox or the acetazolamide, which is a diuretic that can help promote excretion of that excess fluid. If there's a tumor, we can, or if there's a bleed or something like that, we can certainly do surgical removal and do a shunt placement. If it's a tumor or something like that, we can do a shunt placement at birth if they're known to have hydrocephalus. Oftentimes what we do is a VP shunt. That's the most common that you see in kids. There is also another kind called a VA shunt, but for test purposes, I want you to know about the VP shunt, which is a ventroperitoneal shunt that is placed, and that directly will remove and drain CSF fluid. So that shunt, as you can see in this image, it contains the ventricular catheter, a pump, and it has a unidirectional valve that prevents backward flow of the CSF fluid. And then there's also a distal catheter that's placed in the peritoneum to allow for it to drain and then reabsorption through the peritoneum that way. When you think about The nursing considerations preoperatively, again, maintaining the OFC measurements daily if need be, assessing those fontanelles, cranial sutures, level of consciousness and behavior. Again, depends on, obviously you're not going to do head circumference and cranial sutures in a older child, but in an infant you would. But it doesn't matter what age, level of consciousness and behavior, every shift and as needed. You want to support the head and the neck, making sure good skin care, nutrition. We want to offer small, frequent feedings because we want to decrease any vomiting and aspiration issues. Elevate the head of the bed a little bit and encourage bonding. So this is geared at more kind of the infant, but you can still have shunts even in older kids, again, if it is something that is a result of a trauma. So it really comes down to think about increased ICP and your management with that until things are, preoperatively until things are surgically corrected. And then postoperatively, again, you want to still assess for signs and symptoms of increased ICP. Continue to monitor their OFC daily, because by now, if we've surgically corrected it, we want to see that it's starting to decrease. Measure their abdominal girth daily for CSF fluid because we're worried about peritonitis, because think about where that catheter is draining to. It's draining to the peritoneum. And we also worry about not only just peritonitis, but a post-op ileus. Assessing their behavior. We should see improvements in their behavior compared to preoperatively. Positioning depends on what the physician orders, but you want to position them typically opposite the side of where the shunt is. And assess their dressing. Initially on the head and the abdomen, it's usually kept on for at least 24 hours. And of course, assessing the incision site for any leakage, infection, suspected drainage of glucose or CSF fluid, and of course monitoring strict eyes and nose postoperatively. Sometimes with kids who have shunts, they often need shunt revisions. And sometimes they get shunt revisions a lot, other kids not as often. But different reasons we would need a shunt revision: infection, especially if there's like meningitis, the shunt itself becomes infected. And typically we see that usually within the first couple months after placement. If the shunt is malfunctioning and it's not, either the tubing gets cracked, it's not draining properly, whatever the mechanical problem, if there's a kink, a plug in it, again, I've seen ones where the catheter splits, migration of the catheter. And another reason we have to oftentimes do revisions is for growth. As you saw in the previous pictures where they kind of coil up a little bit of the extra catheter is to allow for growth, but sometimes kids just simply outgrow and need to have it lengthened. So they often will need, as they grow older, if they've had it since birth, they're going to need revisions occasionally for that reason. It's always important to manage infections. So treating any infection with antibiotics. If we do vancomycin, we need to look for red man syndrome because that's a pretty common reaction with vancomycin. And other things to think about when you do shunt revisions, sometimes they have to externalize them, which is what this slide is, and there's just a couple other slides. I'm not going to go through those, but just showing pictures of externalized shunts. But an externalized shunt, they'll often do, especially at reasons of infection, if the shunt itself has become infected, and they'll externalize or do what's called an external ventricular device, an EVD, is used until infection clears or that CSF fluid is sterile. So it allows for the removal of the CSF fluid through a tube that's placed in the child's ventricle and then it flows by gravity into a collection device externally. What's really important with a child who has an EVD is that they constantly have to be leveled whenever they move, anytime they change positions, because you level it to their ear so that it's not draining too quickly or too slowly of CSF fluid, because certainly that can cause changes. So again, the position of the patient is dictated by the surgeon with an external ventricular device. If they're allowed to get up and sit up in bed or get in a chair, that has to constantly be leveled by a nurse. And that is all just special education. Family cannot do that, only can be leveled by a nurse. Just one other thing to add when you think about family support and education. With a child who has a shunt, it is really important to make sure family is educated and instructed to recognize signs and symptoms of a shunt malfunction or infection. Especially thinking about shunt malfunction, think about, again, changes in their behavior and some of those signs of increased ICP. We want to avoid contact sports because we don't want to damage that shunt that is located not only their ventricle but also their abdomen. Making sure they wear a helmet outside if they're going to be playing vigorously, just trying to protect that head. And of course, for support, there's a couple different foundations listed there in your notes that you can always help family, have somebody to talk to. It's always important to listen to what they're concerned. Alright, moving into your last disorder we're going to talk about is neural tube disorder. Most commonly referred to as spina bifida or myelomeningocele. Those words are often used interchangeably, but it is a neural tube defect that is present at birth. That certainly affects the CNS and the osseous spine. That neural tube defect is caused by a failure of the neural tube to close in the first 3 to 5 weeks of gestation. And you can see what the incidence is there. It is linked to an insufficient amount of folic acid in the maternal diet. So it's really important, as you've probably already learned in OB, really important for mom's diet to make sure she's getting enough folic acid to try and prevent this. They need to have at least 600 micrograms of folic acid in their prenatal vitamin. But a lot of things are, folic acid is included in a lot of cereals and grain products. But again, when we get into prevention, it's about making sure that they're getting enough folic acid. And then we're going to move on the next slide. All right, there's different types of defects. The first one is spina bifida ocula, which is a defect in the bony spine, which is invisible to the eye, so you can't see it. Typically occurs around L5 and S1. It's not usually apparent unless there's associated manifestations. And usually those you'll see skin depression or a dimple, port wine, stains on the skin, dark tufts of hair. They often can have a soft or subcutaneous lipoma. They don't really have any protrusion of the sac. So it's just, as you can see in the images on your, not only on this slide but also in your notes, picture B, where you just see that opening in the spinal column. But there's nothing protruding. And then spina bifida cystica refers to the actual visible defect, and there's an external sac-like protrusion. And then within that, we're going to get into the two major forms. But with the spina bifida cystica, which is it is what I want you to focus on for studying purposes and for testing purposes. It causes sensory disturbances, usually parallel to the motor dysfunction. Usually it's below the second lumbar vertebrae, and usually you will see flaccid or partial paralysis of the lower extremities, varying degrees of sensory deficit, oftentimes have a lot of problems with incontinence, with urine and bowel. If it's below the third sacral vertebrae, there's usually no motor impairment. They just often have problems with bladder and anal sphincter paralysis. So the two major forms, which when you look at the picture on the slide, C and D, these are the two major forms that we see. Meningocele is a spinal defect, and then that sac-like protrusion is what makes the difference between meningocele and myelomeningocele. And meningocele defect in that sac protrusion, what we have is spinal fluid, and the meninges are present. Usually occurs in the lumbar region, and after the sac, once that sac is repaired and closed, then they don't really have too many other further symptoms because there's no nerves, no spinal nerves in that sac, which can cause further problems. So that's what sets it apart between meningocele and myelomeningocele. In myelomeningocele, or picture D, we have a visible defect in the spine. Again, that sac-like protrusion. But again, what's in that sac? It contains the meninges, the spinal fluid, and nerves. So the degree of the neurologic dysfunction is determined by the level of the sac protrusion and the tissue involved. Most of the myelomeningocele involve the lumbar and the lumbar sacral area. Again, like we talked about with hydrocephalus, hydrocephalus is frequently associated in a complication of myelomeningocele. All children who have myelomeningocele have bowel and bladder incontinence problems. And that's again because we've got spinal nerves in there in that area and has become destroyed, and they have decreased innervation of the sacral area of the cord, which is responsible for bowel and bladder functions. So we refer to those as, when they have the bowel and bladder incontinence issues, it's called neurogenic bowel and bladder. The encephaly and ancephaly, I'm not worried about those. Those are other defects, but we're not going to talk about those. We're focusing on myelomeningocele. This slide and the next slide are just visual examples just to show you the severity of the defect and at what level the defect is. It's just so you can have a visual to go with it. I'm not going to talk about anything else. We'll go on to diagnostics. When we talk about diagnostics with myelomeningocele, we can typically diagnose this prenatally. We can even do a fetoscopy, amniocentesis, or analysis of the MAFP, which is the maternal serum assay. And usually with that, we'll see an elevated alpha fetoprotein level between the 16th and 18th week of gestation. And if that is elevated, then it's going to require an amniocentesis. If it is discovered in utero, they may be able to possibly do fetoscopic surgery and close that lesion. If not, then they're going to wait until birth and close it after birth. They can do MRIs, ultrasounds, and CTs. They won't necessarily do that. They may do some right away after birth, or these also may be things that happen down the line after the closure of the defect. Eventually, we're going to do bowel and bladder function studies down the line as well, to looking at how much control they have with bowel and bladder, which oftentimes they don't have very good control. We can also do some lower extremity neuromuscular testing because they often have involvement, again, because think about those nerves that are in that sac, and those oftentimes unfortunately do get destroyed or damaged during repair. Treatment. If we have a child, a newborn, an infant who we've discovered this in utero, we're going to do a planned C-section. So they're going to be delivered by C-section. And then after that, it's about protection of that sac. We don't want to have a risk of rupturing that sac, so everything is about protecting that sac until surgical closure. So protection of the sac, we're going to do warm, moist saline gauzes, and we want to avoid laying them on the sac because we don't want that sac to rupture. So we're going to place that infant prone position. Unfortunately, until that sac is closed, we want to avoid picking them up and handling the infant because we want to avoid the possibility of rupturing that sac. Surgical closure is going to take place pretty quickly, usually within the first 24 to 48 hours, because that sac, if it ruptures, and why it's so important to protect that sac until surgical closure is because if that ruptures, then we worry about infection. It's an open line of infection right to the CSF and the central nervous system. So again, they try and protect it as best they can, and making sure they do early surgical closure. Eventually they're going to do evaluation of the lower extremity involvement, urinary function, bowel function, studies down along the way. That comes after surgical closure and once healing takes place. They often do have long-term care needs, and it's about promoting optimal functioning, ambulation, mobilization, and establishing urinary and bowel continence. And we're going to get into some of the things they do for that as well here in just a little bit. Physical therapy is needed as well. What I was going to say too is these kids oftentimes need a lot of support, and it just varies. Again, depends on how severe the defect is. They may need help with mobilization. You have some who have decreased sensation, but they do have some sensation in their lower extremities, to some who have no feeling whatsoever and they're completely flaccid from the waist down. So I've gone from seeing kids who are able to walk with supportive devices like a cane or a walker and some AFOs, or to the point, the opposite extreme of they have no feeling and they're wheelchair bound as they get older. So it just really varies as to how big that defect is and how involved it is as to what the degree of sensation is in the lower extremity. Your nursing care for a child with myelomeningocele. Again, it's all about protecting that sac early on. It's focused on that defect. So we want to identify the defect. We want to protect the sac. And of course, when parents can't hold their child right after birth and pick them up and cuddle them, we still need to support the parent and how they can still get, that close contact. They can still go see the infant before surgical closure. They can touch them. They just can't pick them up. We want them to avoid that sac area as well. But it doesn't mean that we can't encourage close contact. We need to make sure we explain all the treatments and things that are going to happen. Pre-op and post-op care, especially important. No different than really what we've talked about with other disorders. The big things that we want to observe for later on, or as necessarily early on too, is observe for hydrocephalus, that increasing head circumference in an infant. Again, hydrocephalus is often associated with myelomeningocele, and again, they may need a shunt placement. We've already talked about that. So making sure we're watching for those. Chiari malformation is another one, and tethered cord as well. Oftentimes with tethered cord, this is something that happens later in life because of that scar tissue that builds up. The spinal cord gets fixed, and it's pulling and stretching on that spinal cord, so then they have to go in and release that. So additional surgeries oftentimes later in life. They'll need physical therapy, oftentimes passive exercises, because we want to prevent muscle atrophy and contractures in those lower extremities. And then with the bowel and bladder, there's two different things we do. Let's talk about the bowel first. I'll actually talk about that on the next slide because there's a picture of what. So with the bladder or the bowel problems, the neurogenic bowel. Some of the things that we can do early on, dietary fiber supplements, trying to prevent constipation. They may need laxatives or stool softeners or enemas. As an infant, it's not such a big deal that they have no control of their bowel or their bladder because they're in diapers anyway. But as they start to get older and they go to school, it is more of an issue, and it sets them apart from other kids. So later in life, they can often create different channels, diversion channels, to help give them more control. And for the bowel, what they'll do is what's called a MACE, and it's a channel where they create through the abdomen. They call it a stoma, but it doesn't look like your typical stoma. There's not any beefy red stoma. It honestly, a lot of times it's disguised, I should say, in the belly button, or sometimes just off to the side of the belly button, and there's just kind of this little slit in the skin that they can actually put a catheter in, and then they'll do saline, basically enema, and what that does is they work up to a certain volume, so it's not like you have this huge massive volume that they do, but they put the catheter in through the stoma, hook it up to saline or water enema, and let that enema go in basically by gravity. And we oftentimes put them on the toilet right away because they can have a bowel movement anywhere from immediately after to sometimes it takes 45 minutes to an hour. But what that does is that enema basically pushes the bowel movement out for them since they don't have the control. They've lost that function. It creates the bowel movement for them. We work up to this. They do it one time a day, usually at night, and they kind of get into this routine, and they can have a normal bowel movement out through the rectum. They just don't have the control, so the enema forces the bowel movement for them, which is really great because it gives them a lot of independence and gets them on a schedule, and then they're not having to wear diapers and they're not leaking, which is really great when they're going to school. And the other one, what we do with bladder incontinence and the bladder dysfunction or the neurogenic bladder that we have, we create what's called a Monty. So again, it's another diversion channel that we create where they can intermittently cath themselves. A lot of times because of bladder incontinence when they're younger, as an infant, we can do intermittent urinary catheterization. But then again, as they get older and they're going to school, to give them some more independence and more control, and of course to be like other kids, we can create what's called a Monty channel, which is where they self-cath through. Again, they'll create a stoma, but it doesn't look like your typical stoma. It's just a little slit in the skin near the umbilicus, so it's not in the umbilicus. It's usually just off to the side, and they'll usually do this early school age. I've seen usually around 5 or 6 years of age is when they'll create this. But they basically put in a catheter just like you would an intermittent urinary catheter, except instead of going through the urethra, we're going through this stoma in the abdomen to the bladder, drain off the urine, take the catheter back out, and that's it. So it's just another way to cath them. And again, they'll oftentimes create that conduit or that channel oftentimes with the use of their appendix. You don't have really, as long as they haven't had an appendicitis and have it already removed, they'll use part of that appendix to create that channel. And sometimes they'll create like a bladder sling or to be able to hold more urine because they oftentimes can't hold very much urine. But again, it gives them more control, and they cath several times a day and gives them more normalcy. And a school-age child can learn to do this on their own. They can go into the bathroom, cath themselves, and go on about their day just like any other kid. But because of this too, and just myelomeningocele kids in general, we often label them as a latex allergy because they are such a high risk for latex allergy because of the repeated exposures to their CSF fluid, their CNS system, which often, most things anymore in the hospital are latex free, but it is still something to be aware of. And again, needing to reduce that exposure at birth and with any procedures and surgeries that they have. We want to reduce, or not reduce, but eliminate latex exposure.